welcome. My name is Bernadette Melnick, and I am Dean of the Arizona State University College of Nursing and Health Innovation, and I am particularly delighted to welcome each of you here today. We are addressing two major child health epidemics in our country today, that of overweight and obesity, as well as child mental health disorders. We have reached an era where mental health disorders are as common as childhood fractures. 1 out of 4 children and adolescents now have a mental health disorder, yet less than 25% receive any treatment whatsoever at all. 1 out of 3 children are now overweight and obese, and that is even more prevalent among minority populations. We are here not only to talk about these particular issues, but we are here to generate bold, innovative solutions. Our goal for this forum is that we take the bold, innovative solutions from this wonderful expert panel and turn them into action tactics to improve both of these child epidemics. So right now, I would like to introduce you to our distinguished panel. First, to my left, Dr. Q. Rhee is Chief Public Health Officer with the Health Resources and Services Administration of the United States Department of Health and Human Services. He is a pediatrician whose work focuses on obesity and health disparities. Next, Madeline Clark is one of 25 youth advisors from across the United States with Alliance for a Healthier Generation. Next, Dr. Peter Jensen is a child psychiatrist with the Mayo Clinic and also president and CEO of the REACH Institute, which disseminates evidence-based interventions to improve child and adolescent mental health. Next, Joanne Kennan is a health policy writer, journalist, and founding editor of the New Health Dialogue blog at the New America Foundation. To her left is Marie Morillas-Black, who is Director of Children and Youth Services for the D.C. Department of Mental Health. To her left is Russell Pate, an exercise physiologist and professor at the University of South Carolina Arnold School of Public Health. Today's panel will be moderated by highly respected health reporter Deborah Kotz. Deborah recently left U.S. News and World Report to launch the Daily Dose, a consumer health blog at the Boston Globe. I would now like to introduce my wonderful friend and colleague, Dr. Rich Carmona, the 17th Surgeon General. Rich, I have had the wonderful opportunity to get to know Rich well over the past couple of years. He was born to an immigrant family in New York City and experienced homelessness and other adversities that take such a negative impact on the trajectory of children. He is both a nurse as well as a physician. He served in the Army. After getting out of the Army, he went to medical school. He is a trauma surgeon and set up the first trauma program in southern Arizona. In 2002, he was appointed the 17th United States Surgeon General. Rich is passionate about health promotion, wellness, and health disparities, and it gives me great privilege to introduce him today.
Thank you, Bern. I appreciate the opportunity to be with my colleagues today and to set the stage for a few minutes on this very important issue. Indeed, children are in peril today for many reasons, but probably none more important than the issue of obesity and the intersection with mental health as well. There are a lot of people that are stepping up to deal with these issues, and before I make a couple of substantive remarks, I wanted to recognize our uniformed services officers who are here from the United States Public Health Service, to thank them because they often are the silent heroes behind a lot of things that are done at the federal level in health. Would you all stand up so the public can see you? Thank you. And Dean Melnick, it's a pleasure working with you and having you as a colleague, and I'm thrilled with the changes you're bringing to nursing in general and health, but more importantly, the platform that ASU has given you to be a health innovator nationally and globally, and to bring groups together like this group here to address some of these issues. I'd like to, for just a few minutes, give you a Surgeon General's perspective of this issue of childhood obesity and some of the intersection with mental health. And of course, the expert panel will be discussing that a little bit more. As Surgeon General of the United States, it sounds like a deceivingly simple job. The statutory job description is to protect, promote, and advance the health, safety, and security of the United States. And of course, nothing could be easier, right? In a very partisan environment, it is often difficult to drive thoughtful science forward. And as I took the office of Surgeon General in 2002, one of the challenges that I saw was this issue of obesity. My predecessor, David Satcher, the 16th Surgeon General of the United States, had started down that road, but it was difficult. There's a lot of competing interests in the United States. And of course, as I was in office, we have two wars that we're involved in. We have an anthrax threat, and it's very difficult, as we say in the Beltway, to get traction on some of these issues. And yet, as I looked forward, I saw the evidence was so compelling. And as I looked at my portfolio and what should the Surgeon General of the United States be doing, it was quite clear that prevention had to be moved first and foremost to the forefront. After all, when we look at disease and economic burden in the nation today, and we look at what obesity contributes to that, there was no other way to go. Spending 17% of GDP on health care. In fact, it's really sick care, folks. It's not health care. The fact of the matter is, when we look at the disease burden that increases every day, the economic burden that concomitantly increases with it, we see obesity embedded in every bit of the portfolio that I was responsible for. So as I looked at prevention, I also saw 9 million children who were overweight or obese and increasing on a regular basis. I saw unprecedented rates of type 2 diabetes around the country and the world, because the world was becoming more westernized and becoming sedentary and eating the wrong foods and the wrong amounts and so on. As I looked at my entire portfolio, not just prevention, but when I went to preparedness, it was clear to me that there was an intersection with obesity and mental health and national preparedness. In fact, I characterized it as a national security issue, which created a bit of heat in Washington because I was competing with a legitimate war at the time. But the fact was, I thought this war was at least as important, if not more important. The fact of the matter is, as I went to various press conferences and the Surgeon General was asked to speak with Congress or the press, often the discussion then was about national security, weapons of mass destruction, how do we protect the nation? But I started to see a thread weaving through this portfolio of mine, which was about prevention, preparedness, health disparities. And one day at a press conference like this, where I was talking about early warning procedures as it related to emerging infections and how to define a naturally occurring event versus a terrorist event, one of the reporters said to me, "Well, Surgeon General, what is the biggest problem that you are dealing with today?" And I said, "Obesity." Nobody knew what the next question should be. Everybody was geared up to talk about terrorism. They said, "What do you mean?" I said, "Obesity is the terror within." And I said that for a purpose, because during my first year, as I tried to talk about science and get traction on the issues based on substantive discussion, I was competing with a lot of other things in the media. And health really, and science really gets the headline for its own merit. So characterizing this as the terror within brought a little bit of a claim to it, if you will, and got a little bit of attention. But as I went through the portfolio and I looked, and I said, it's also a national security issue, folks. And they said, why? I said, well, the number one reason that our young men and women fail to be retained on active duty in the uniformed services is obesity. So I would submit to you that this is a national security issue because we don't have enough boots on the ground, as we say. What's happening in the future, as we look to the future, we look at workforce diversity. What happens as we look to the future to who will fill the shoes of our sailors and soldiers and airmen? Who will fill the shoes of our first responders, police and fire and so on, who keep our community safe? The fact was pretty clear that as we looked at trajectory going forward, we would not have a cohort of young men and women who were able, physically ready to take on this job, because my CDC epidemiologist had said to me back around 2003, Surgeon General, this could be the first generation of children that lives less than its parents because of the disease burden inflicted by this epidemic of obesity. And so when I looked across the board at everything I was doing in prevention, preparedness, health disparities, you say, what does it have to do? Well, the fact of the matter is there's a disparate representation in people of color and lower socioeconomic groups of obesity. Their disease burden tends to be higher. It costs more. So there's an economic imperative here. There's a workforce diversity imperative here. There's a national security issue imperative here. Every one of those are in the forefront. And we see mental health hovering there also. Because if you're an obese child, you have a higher incidence of mental health problems. If you're obese, you have the accelerator of chronic diseases or the cause of diseases. Cardiovascular disease, asthma, low birth weight babies. I mean, the list is endless when you see how pervasive it is as it relates to disease and economic burden in our society. So as we look through our respective lenses and we try and determine what is it we should be doing, we should not forget that this obesity epidemic and this mental health challenge affects every single segment of our society. And the fact is, if you're a young child and you are overweight or obese, chances are you have a higher incidence of depression. You're not going to be the cool kid who gets invited to the prom. You're not going to be on the sports teams. You're going to be ostracized often. So we see mental health is intersected with this physical health problem. So today, I'm thrilled that Dean Byrne-Melnick had the vision to see this as an important issue that should come to the national forefront, to assemble thought leaders, national thought leaders on this issue, so that we can begin a dialogue with some execution. Where do we need to go next? What is it that we need to do? We have no choice but to act today. This is a critical issue in the health of our nation. It needs to be part of our strategic plan as we move forward to make the nation healthier. And I think that discussion can begin today and add to all the other discussions that have been before us in the last few years and really have a meaningful approach to how we deal with this complex issue. Thanks very much.
Thank you very much, Dr. Carmona. And thank you very much for inviting me to be here today. It's my honor to be a moderator of this very important panel. I think that the timing actually couldn't have been better given what happened in Tucson 2 weeks ago, and the fact that we are talking about mental health issues, we're talking about obesity, and as Dr. Carmona said, we're talking about prevention first and foremost, and you know, how do we get here? How are we dealing with it now, and where should we be going in the future? So Dr. Ree, with that, I'd like to start with you. Given that you are in the public health field, wanted to get your thoughts on how you think this obesity epidemic started 30 years ago, and what you think we are doing wrong, if we are doing something wrong, and you know, how this problem really got underfoot.
Thank you very much. The paradigm I like to kind of think about things is more of a public health paradigm, and I think when you think about how we as a country have done well from 1900 to 2000, the average life expectancy in 1900 was, do people know this? What was it? 47, 48, yeah. So, and then in over 100 years, we gained about 100 years, over those 100 years, we gained about 30 years of life expectancy. So it's been well researched that 25 of those 30 years were related to kind of our focus, which was public health interventions and looking at the conditions of the time that were really affecting people's health, like infection. And clearly there were so many innovations as it relates to vaccinations, antibiotics, sewage systems, and hygiene and things of that sort. And so I think what we have now is a situation where we have to recognize that our current crisis is related to things like chronic conditions. And the biggest contributor, really, if you go further upstream, I think we've been very focused in our healthcare system downstream. at where health ends as opposed to where health begins. We've got to realize that the focus has to be going further upstream, and I think we've lost our focus, and some of our systems have been built around that paradigm that's really focused more in a different paradigm, which a chronic disease paradigm will really require us to think differently. I also think we've in some ways siloed our approaches. I mean, how can you assume physical health is not connected to mental health? Of course, every physical ailment. I mean, when I hurt my leg and tore my ACL and couldn't play sports, I was depressed. I mean, I was not happy that I couldn't do the things that I used to do. So I really think how we've sort of siloed physical health and mental health is also a significant kind of disservice to the reality of life. So those are a couple things.
Marie, given that the obesity, I mean, you probably see both of these as a mental health professional. You're seeing probably, many of the kids who are coming in to see you with depression in the DC school systems, may also be overweight, maybe dealing with both factors at the same time. Have you seen a rise in mental health problems in the school system there? And do you think that it is related to the obesity epidemic, or is it far more complex than that?
Good morning, everyone. I do believe that it's a bit more complex than that. I do agree with Dr. Ree in that there is a big correlation between obesity and mental health. Moreover, there's a big correlation between parents dealing with mental health and the emerging obesity and mental health of their children. And I believe in some of our panel discussion earlier, we were talking about some specific studies that Dr. Pate might, address in his panel in regards to some of that issue. Because one of the things that we found, although Dr. Ree was mentioning about the increase in age in in life expectancy since 1900s, what we found in mental health adults, comorbidity studies have shown that for adults dealing with mental health, their life expectancies is 25 years less, even today. So when you start looking at the emerging of children with obesity, 1 out of 3, then you have to look at the parents that are dealing with mental health that are possibly untreated, and that also impacts what's happening with the children because they are not taking care of the kids in the way that they should. So I think there's a big correlation between family issues and emerging mental health in the schools that we see. And as a result, one of the things that we're working in DC is increasing family participation in mental health, school-based mental health treatment. And as of last year, as I was sharing with you earlier, we've shown a 51% increase in family participation from last school year to this school year because we're making more of an emphasis on that.
Mm-hmm. Moving towards more of a holistic approach.
Absolutely.
Bernadette, as a nurse practitioner, I was actually shocked to read the statistic that I think you brought up with that 25% of children with mental health issues don't get the proper treatment. And it sounds like in DC they're certainly making strides towards trying to get more children treated, but on a national level, why is this such a problem considering that we do have more awareness of it now?
There are multiple factors. I think we need to realize that these frightening statistics are believed to be even higher, due in large part to inadequate screening by primary care providers. I do multiple workshops for nurse practitioners as well as physicians on how to assess, how to screen for, identify, and manage these problems in primary care settings. And a very frequent response that I hear is, Bern, I really don't want to screen because if I screen and I find I have nobody to refer these kids to, and I myself don't know how to treat them. So I firmly believe we have to prepare a workforce that is duly prepared to deal with both physical and mental health problems. And we have to integrate physical and mental health care in primary care where families feel comfortable to take their children to deal with common concerns.
On that note, I know Dr. Jensen, that as a psychiatrist, this is a key issue with you. How do you get the primary care physician more involved in not only obesity but in the mental health realm when they're clearly not trained in some of these areas. What is the problem here? I mean, they're the gatekeepers of children's health. Why do they seem to be so ill-equipped to at least refer these kids on or make sure that they're getting the proper help?
Well, it's a wonderful question, and I think it perplexes really kind of the national healthcare system. The Surgeon General and the former Surgeon General both noted that if we're going to fix mental health in the country, the fix has to be in primary care. It won't be by, creating more child psychiatrists and psychologists. The problem is that most primary care providers are not trained during their residency. They're trained in things like the neonatal intensive care unit, things that actually help pay for the cost of the residency. And they do not get trained in simple things such as, in almost all instances, depression or ADHD or even behavioral management strategies to mobilize a family to deal with things like obesity. So what pays the bill for the residents' training drives the content, and it's expensive medical procedures that are billed for example, in a NICU or a neonatal intensive care unit. The other part of the problem is on the downstream end, is the healthcare systems have generally taken things like mental health and carved it out. And what that means is you might be told as a primary care provider you cannot bill for mental health problems, even though the family does not want to go see someone like me, say the shrink. They want to see somebody who's kind of real family friendly. And so they didn't get trained during their residency. They're overwhelmed and they're scared because they don't know where to refer to, and they can't bill. And so the only way to really get, I think, our hands in front of this are, and this is actually one of the things we've started developing with the Reach Institute, is real hands-on intensive training for primary care providers, including teaching them how to bill, because they don't know that either. And there are some actually things that they can do. So this has been one of the partial solutions to that problem, but it's going to have to be a complex, going back to residency training programs, getting out there with doctors who are out there in the field now, working with healthcare insurance companies, and working with families who put this at the top of their agenda to make sure their children get that kind of more complex care in primary care that has to address the behavioral issues, including obesity.
Mm-hmm. And obviously exercise is one of those key issues as well. And Dr. Pate, as an expert in this area, I'm wondering where you think the problem began. I mean, kids were always outside playing. They were always active. We never really talked about kids having to get formal exercise. Nowadays, it's the top of the First Lady's agenda, the top of our national agenda. How do we get to this point?
I often say I don't remember much about what I was doing when I was 5 years old, but I know what I wasn't doing. I wasn't watching TV. I wasn't text messaging. I wasn't surfing the internet. Our society has changed in incredible ways that have had the collective influence of reducing the demand for physical activity that our children confront on a day-to-day basis, and in many cases placing barriers to their being physically active. I don't want to overstate the issue. I don't think we, in the long run, benefit ourselves or the issues that we're concerned about if we overstate them. But our children were not designed to be sedentary. Our bodies are designed to be physically active, and in my view, we don't do well when we're not at least reasonably physically active. We now have very good data at the national level that shows that it's a minority of our children that meet current physical activity guidelines. And I think we have to ask ourselves how we're going to turn this ship around. It's not going to be easy. We now have a national physical activity plan that's organized around 8 societal sectors. There are over 250 specific recommendations in that plan, and some may be more important than others, but I don't think any one of them constitutes a magic bullet that's just going to solve this problem. But I think the problem can be solved for many of us in this room, in our lifetimes. This problem has developed. That means that we can change it. We can move it back in the other direction. but we're going to have to invest. We're going to have to commit to prevention because treating these problems that we're here talking about this morning is not a happy proposition. Much better to prevent both of them, and I think we can prevent them, and I think increasing the physical activity levels of our children will be one of the key strategies that we'll have to employ if we are going to prevent them.
Joanne, as a health policy reporter, I'm sure you've covered time and time again the problem of obesity, the problem of mental health problems in children, and I've covered them as well. And I'm wondering if you've heard any, in speaking with your sources, is there any optimism when you interview them, or is it all sort of the doom and gloom negativity of we're all heading down on a downward spiral?
I think that the thing that everybody in Washington is, of course, screaming about at the top of their lungs is healthcare reform. And the things that we focus on politically are the controversial things about the role of government and how much it costs. If you dig down, there's a ton of stuff in that legislation that people, when they're not screaming, which admittedly is not very often, can actually agree on. And there's a lot in there that has, we don't know what's going to work and what's not going to work. But there's a lot in there that really, as Dr. Carmona mentioned, really attempts to turn the healthcare system from running after crises, and treating everybody in ICU, and beginning to really think about wellness on one level and moving from an acute to a chronic disease system on the other level. And so there's a lot. So, it depends. There are days that I talk to people who are optimistic, and there are days that I talk to people who are pessimistic, and everybody I talk to is angry at somebody else. But there is, and every time, and I've read I've read a lot of the legislation. I've read countless summaries. I mean, everybody has a summary, and I went through the National Mental Health Association, the MHA Association summary on this. And every time I read any of these summaries, and there are dozens, I come up with something I didn't know about that actually makes me feel optimistic about school clinics. There's stuff in I keep calling it the bill. It is the law. And the House didn't change that. School clinics are getting funding. Community health centers, which is really going to be an incredible tool for the Medicaid expansion and for covering the uninsured between now and then. Community health centers got billions of dollars, and they got everybody got more flexibility in experimenting on how do you deliver care. So as Dr. Jensen talked about using the primary care system, and he talked about the obstacles in training, there's also lots and lots and lots and lots and lots of obstacles in payment, because our system really rewards doctors who do things to you, and it doesn't really reward people who talk to you. Okay? And what do my pediatrician talks to me. I'm lucky. Well, she talks to my kid. My pediatrician is so good that when my kids came home and asked for broccoli, okay, so. Only one of the two kids. So if we move to a system where there's more flexibility in how doctors are paid, and not just doctors, but using nurse practitioners and using PAs and using other, to deal with some of these issues of weight control, obesity, they're not paid to sit down and tell you why you need to eat broccoli or why you should get excited about broccoli. But in new payment models in medical homes, because the payment, without getting really wonky about it, it's more flexible, and doctors will have new ways of organizing and delivering care that they can talk to you more, if it all works. And some, I think there's so much, one of the most pessimistic economists in Washington actually said there's so much stuff in there, some of it has to work. So, it's Bob Reichow. Anyone who's met him, he's sort of a gloomy guy in some ways. And I feel that way about, some of the models. And it's so much part of our dialogue in a way that it wasn't before. So, we can talk in more detail on some of that.
Great. And on that note, actually, we'll move in a little bit towards part two, which I think is very key here, is sort of looking at some of the remedies that we're trying out. As you say, there will be some that we'll be trying out in the new law, as well as what's happening right now. So Madeline, our youth expert, I want to turn to you because we spoke a little bit, and you told me you're really active in school sports. You're on field hockey and soccer. I think you said you were a swimmer. And I'm wondering, we talked a little bit about the jock club at school, and then the kids who maybe don't fit into that, and how do we get them exercising? How do we get them excited about fitness if maybe they're a little reluctant to join that school team?
Well, I feel like we should start having more intramural sports at school where anybody can join in, and it's not just for the people who can make the team or who can be the biggest and or the best at anything. But also, we need to start utilizing having PE classes in school, because at most schools they do things in PE. It's a social sit-down hour, and we need to start teaching about nutrition and exercise in those classes, because they'll teach you about like drug abuse and alcohol abuse, and they teach sex ed in there, but what we don't have is a nutrition class, and they don't teach us skills in how to exercise correctly, or how many minutes a day do we need to exercise, and it's basically seen as a punishment until you get out of the 10th grade, and then you're just like, thank goodness that's over.
Dr. Jensen, wondering what you think in terms of the issue that we raised before about, as Dr. Kimono was saying, obese kids are not the ones who are invited to the prom. They're not the ones who are the cool kids. They're often the ones actually who are bullied, which can lead to a host of mental health issues in and of itself. And I'm wondering, are there any solutions to change the environment in schools to sort of take the stigma off of obesity without sort of saying, hey, this is a perfectly acceptable way to be from a health standpoint?
Well, I think a number of folks have developed strategies for schools that kind of mainstream the behavioral health. As soon as you basically say you're in a special category, you stigmatize it. And so if you say you're a mental health kind of kid, or we've got a class for the fat kids, well, you can definitely be sure that that's going to be a group no one wants to be a part of. Mm-hmm. And so the conceptual approach has to begin, something like both Dr. Kimono and Dr. Reed talked about, it has to be built into the entire fabric of how you think about health. And so you don't think about there's some who are healthy and then some who are sick. No, you think about how do we embed health thinking all the way up throughout this. So that means healthy lifestyle, that means healthy coping strategies, healthy behaviors in a school setting. And so I think someone like Madeline's talking about how do we embed that so it's a part of the fabric of the school. Now, people have done, and I know less about the obesity area, but I can say I know that people have done that very effectively in changing the climate of schools so that kind of positive behavioral health is woven throughout. And when the child has some increased level of needs, it's not like, oh, you're one of those. No, it's just kind of everybody's worried about their behavioral health. Everybody is owning the mental health issues. Everybody's owning the physical health issues. And it's something that we all are doing, not those people over there are doing. And I think, but that means training of the janitor, to the receptionist, to the school clerk, to the principal, to the teacher, to the student body. And in that kind of strategy, we see some very important turnarounds in schools where the climate changes and then children change as well as a function of that climate.
Mm-hmm. Dr. Ree, I'm wondering if in your area of public health, if you've seen the role of stress that stress plays, which is something that we haven't touched on yet, both in terms of kids becoming more overweight as well as depressed and developing more severe mental health issues. Are there any efforts that the government is taking? I mean, they can't really, tell schools to, because we clearly want to enhance the educational standards of our public school system, yet some people are claiming, well, that's just leading to more stress in our children's lives.
As a primary care physician, I definitely know what stress is like. So I think, and I wanted to make a comment on the issue of the issues related to primary care, because I think it would help people understand. In terms of what government is doing to address stress, though, to answer your question, I think we're doing quite a bit to be much more transsectoral, much more trans-HHS. I think, frankly, part of addressing stress is knowing that there's someone else out there who's has the same mission, the same challenges, and has resources that might be allocated in a different silo, but actually realizes there's an opportunity to leverage those resources in a more integrated fashion. I'm really, I do want to refer to some components of the Affordable Care Act that HRSA specifically is leading in school-based health clinics. There's $250 million for school-based health clinics, and we got so many applications, and so there's clearly a huge demand for that and thinking about health in that framework. And I think we have to think outside the traditional healthcare frameworks of hospitals, out in the community. Because frankly, as a primary care physician in a community health center, I only got 10 to 15 minutes per patient, the way the system is built. And half of that time I'm documenting the visit. So when you've got people who speak different languages, other cultures, and they bring so many other things, and frankly the culture is I want a prescription for something, it's very challenging to be thinking about broader, issues of counseling. Community health centers, there's currently about 19 million served in community health centers in about 8,000 sites in our country. The demographics of this population is very health disparity focused. Greater than 90% are less than 200% of the poverty level. Greater than 70% are less than 100%. 2/3 are minorities. Half of the sites are in rural settings. There's about 125,000 staff serving in these centers in very high-stress environments. And so what's exciting about the Affordable Care Act is over the next 5 years, that number is expected to double in terms of the number of people served. And just think about the demographics of that population. We're very happy. Recently we announced that I think what you measure determines what you do. And so we have just added a metric that we are expecting our health centers to track BMI and also the counseling in response to that BMI. I think this is going to be very important to help address this epidemic. I do know what's challenging, though. I mean, when I see patients, I'm just thinking, in that 15-minute visit, I say, I see someone is clearly overweight and the child is, looking depressed, and I've got that 7 minutes and it's ticking, and I might have a translator there who's, so maybe I have 3.5 minutes. Why? And the messages that I have available to me are like things like 5210. What's that? What's 5210? And we often in medicine choose these quickie messages with acronyms and things to remind us of things like 5 fruits and vegetables, 2 or less hours of screen time, 1 hour of physical activity or more, and almost 0 kind of sugar sweetened foods and beverages. And it's very challenging to be in these settings where you're kind of in a culture of trying to provide a prescription for health, a prescription for a quickie message, when you don't have other opportunities to be more innovative at times, partly because you don't have access to those resources. I mean, and I think the innovations exist in things like group visits. There's more time. You need more time for those relationships. I think being non-healthcare sectoral, so school, other settings, getting other partners to the table. I love the quote, if you're not at the table, what are you? And it's kind of relevant. You're on the menu. So no one likes to be on the menu. So you need to bring the other sectors that are relevant in this issue beyond just healthcare to the table to try to address this issue. And then you have to really keep asking why. Because I ask those questions. Why can't you get the fruits and vegetables, 5 servings? Well, we don't have any. It's too expensive. I can't afford it. Or I just have the 7-Eleven down the street. And why can't you do the 2 hours of screen time? Well, I can't get outside. There's not enough. There's no parks. Or so it's better to just turn on the TV. Or, I feel worried about the crime, or if I got 3 jobs, I can't work, Why can't you get the physical activity? Well, the school doesn't have the system, you heard that. Why can't you get the sugar-sweetened, foods and stuff? Because, well, the most affordable thing is a fast food restaurant down the street, and that's what I can afford. So you keep asking why. I love the scientific method of the 4 whys. Just keep asking why, and then you understand a little bit more about the cause, and then you have to try to provide the interventions. And I think our interventions have been focused more on clinical care settings when we have to be broader than that. So.
I think it's also just recognizing the fact that it's so tough to get somebody to change a habit. And you named 5 or 6 different behavioral changes to throw at somebody in one visit, and how do you get them to change that? And Bernadette, as a nurse practitioner, I think we're going to probably start seeing a lot more of those involved in practices, especially with the Affordable Care Act, recognizing that we need more than just physicians to be treating the patient population. So I wanted to ask you a little bit about some of the work that you're doing.
Well, As both a pediatric nurse practitioner and child psychiatric nurse practitioner, I have long integrated physical with mental health care. We are funded right now by the National Institutes of Health and National Institute of Nursing Research to test a 15-session cognitive behavioral skills building healthy lifestyle intervention program with 800 teenagers in the Phoenix area high schools. Now, if we take a look at the body of evidence in terms of what interventions work to really change behavior, because we know information alone isn't going to change behavior. And when you look at what has worked, we've used a lot of multi-component interventions that consists of nutrition education, physical activity, and mainly behavior modification. But we're not seeing long-term sustainable change with those multi-component interventions. And what our team believes is we're missing the cognitive behavior skills building piece, the mental health piece. Our research has shown with hundreds of teenagers that how teens think is directly related to how they feel and how they behave. And our research has also shown when a teen has higher depressive and anxiety symptomatology, or they have poorer self-esteem, they don't engage in healthy behaviors. They see them as more difficult. So again, we're teaching teachers how to integrate this 15-session intervention program within the school health curriculum and studying the effects of that intervention on both physical and mental health outcomes as well as academic performance, because most studies have not looked at mental health outcomes of healthy lifestyle interventions or academic performance. We've got to tie all of those factors together. So we're very excited about this particular work. It is a new, what I think, innovative, fresh approach to improving both physical and mental health care of our adolescent population.
And Marie, you had some pretty good results with some innovative approaches that you've been doing in the DC system. Can you tell us a little bit about that?
We have a robust school-based mental health system, and one of the reasons it has been so successful is because it integrates prevention, intervention, and it also, whenever feasible and when appropriate, integrate family involvement. One of the things that I found nationally that we miss often is the family component. What we learn is that families have huge influence on their children, even at the adolescent level. Although, as we were talking earlier, that peer influence increases, parent influence does not go away. It still remains high. Exactly. So we have to and our mental health system often has been focused on the child-specific intervention. And we do not integrate the family component enough in the treatment of people's children. And I think that the other piece that I also want to say is that there is huge stigma, particularly in the minority community, around mental health services. So we have to, and if you look at SAMHSA's data, minorities are currently overrepresented in high-end services in the system. In mental health system. So as a result, we are not reaching those minority population early enough in the prevention and the wellness component of their care. We have to change that as a community nationally. We have to, I agree, we do need to have screening occur at the school and or at the primary care level. Every children goes to school in this country. It's a law. We have access to them. And so we have to use school as a natural setting to integrate mental health and behavioral and the teaching all in one in this country. And we have not done that. And what we found is that when we do that, it works. We reduce the number of children that are in special ed. We reduce the depression. And what we have found in our school-based mental health program is that children will self-refer because we have a drop-in center. So there isn't the stigma as this clinic in the back of the hallway that only the problem kids go. The way we've set it up, it's a drop-in center so that children can go if they need someone to talk to. If they need ongoing treatment, there's a case that's open, then they can do that. We really need to look at that setting as how to integrate that better and to pay for it, because funding is an issue across the country. If you talk to the national directors of mental health, what they will let you know is that there isn't consistent funding for children's mental health in this country. And so therefore, services are not consistent enough for us to really show the outcome. And I am excited about the Affordable Mental Act, yes, the Affordable Healthcare Act, because a lot of this have been woven into the fabric of that. However, we do know, and I have a quote that I say is that plans without corresponding control is hollow hope. And so we have to have a plan. We have to have a way to measure if that plan is being executed. And then we have to we have to manage and measure what we do.
I'm curious actually where you get your funding from, because as we spoke about before in the recession, we have public, you mentioned that your nephew in Atlanta was having to now pay for his track in a public school, and I'm wondering how your program has survived in the recession. Are you getting private funding? Is the city of DC funding you?
We are very lucky in DC, where the school-based mental health has had such wonderful outcomes that it has been one of the fabric of that the local government has continued to fund it. However, we, as of a couple of years ago, deemed the school-based mental health a clinic in the school clinic. So therefore, when we provide treatment, we also can bill for that treatment. And so we have two sources of funding. The local government has been, kind and consistent enough to provide us the local dollars, as well as we are now billing for some of the actual billable services that we provide.